Good afternoon, ladies and gentlemen. I'm very grateful to the organizers of this conference for inviting me. As it's been said there, I'm a psychiatrist, work in the National Health Service in the UK, and as my friends will testify, I'm also a completely sane human being. I'm going to try and present 13 slides in 14 minutes and 30 seconds.
13 as well.
And so, if I apologize beforehand if some of the material I present seem too technical, but I will try and explain as I go along. I'm going to be speaking about trauma from a clinical perspective, and towards the end of my talk, I will also speak as a human being and a Nigerian, as someone who has a stake in that country. Right. First, I want to talk about the evolution of diagnostic concepts, why clinical labels attached to human experiences. It's been recognized from very many years, many centuries actually, that trauma, however defined, leads to psychological effects in people, and that those effects apply to individuals and they affect groups, human groups, communities. But the modern understanding of what we call post-traumatic sequelae started really, in Western psychiatry at least, after the First World War, when it was recognized that distinct symptom clusters were observable in people who had been exposed to war. Various terms were used then: shell shock, battlefield neurosis, or in some cases, people were simply shot for being cowardly. But as time went on, especially after the Vietnam War, it was recognized that there was a need to codify these diagnostic systems so that, one, the jobs would be easier for psychiatrists like myself when we speak amongst ourselves, so that if a psychiatrist in New Zealand says, I'm talking about, a diagnosis of PTSD, for example, another psychiatrist in Nigeria will immediately understand what they're talking about. So that gave birth to diagnostic categories. Well, the first thing I would say is, none of what I say in this talk should be taken to mean that everybody who has exposure to trauma develops psychiatric problems. Actually, most people who are exposed to trauma seem to get on with their lives and live normally. But there are a range of disorders that could arise after exposure to trauma. The most important one, or the simplest one, is what we call acute stress reaction in clinical psychiatry. There are also adjustment disorders. There's the one that's quite popular, post-traumatic stress disorder. Among psychiatrists, it is said to be one of the few diagnoses that patients actively seek, certainly in the UK. There is acute polymorphic psychotic disorder. There are dissociative disorders, which in the past used to be called hysteria or hysterical reaction. There is a depersonalization, derealization syndrome, which is just an extended process of alienation from the environment around you. And there is enduring personality change after a catastrophic experience. Now, this is very important. By the way, it's an unwise physician who makes remote diagnosis, but there is a Nigerian general, retired general, who, when you read the account of his wife, you get a distinct impression of a marked and enduring personality change from after his experience in the war. Of course, I will not mention names. Right, so I've chosen one of the categories above to illustrate my example. I mentioned PTSD, ICD-10 diagnostic criteria. One of the ways clinical psychiatrists have codified these systems is by the manual what we psychiatrists call our Bible. ICD-10 there stands for International Classification of Diseases. The 10 there is chapter 5, but this is the 10th edition, essentially. It's published by the WHO and is used worldwide. Well, I say worldwide, excluding America. So I guess you could say it's used in the civilized world. But what this system tries to do is to essentially group symptoms into 3 clusters. So you have the stressor criterion. So the nature of the event inducing the trauma is specified. And really, it's nothing particularly complicated. It says it's an event or situation of exceptionally threatening or catastrophic nature. And it is likely to cause pervasive distress to almost anyone. Almost anyone. And then there are symptom criteria. Some of these we might have come across in various forms. Repetitive, intrusive recollection or reenactment of the event in memories, in daytime imagery, or dreams. A sense of numbness or emotional blunting, detachment from others, unresponsiveness to surroundings, and the last bit there, anhedonia, loss of pleasure, inability to gain pleasure or satisfaction from usual pastimes. For example, not being able to enjoy football. And another cardinal symptom is avoidance of activities and situations reminiscent of the trauma. And then the last group of symptoms are symptoms of what we call autonomic hyperarousal. I will explain this very briefly. Let's imagine that a lion got into this room. How might we respond? I suspect not very calmly. So we will have involuntary reactions to the presence of danger. That's the way human beings are wired. And the part of the nervous system that does that is the autonomic system. So imagine, if you will, a system that is tuned or that is designed to make you respond to danger. Now imagine that that system is turned on when there's no danger. That's what we mean by autonomic hyperarousal, and it manifests in things like hypervigilance, enhanced startle reaction, and insomnia. Because, of course, when you're asleep, you are very vulnerable. In the ICD-10 manual, these symptoms are required to have been present for a month. The reason for that is to differentiate them from the acute stress reactions and the adjustment disorders, which are of slightly shorter duration. And importantly for treatment, are self-limiting. They don't need medications. They simply hold the patient's hands. The Americans include a disability criteria, but in the rest of the world, we don't. Right. So what happens in the brain? I'm running out of time. So I'll briefly mention that. First, how do we know what happens?
You have about 5 minutes.
Okay. Yeah. So all the changes in the brain are indicative of a chronic stress reaction. So essentially, that system that I talked about earlier is hypersensitive. It's like a thermostat that's extremely sensitive, much sensitive than it needs to be. And that's what happens with all these things. All the things I mentioned there are things that you can observe in the brain, both in animal models and in humans. The serotonergic system, serotonin is what's called the happy hormone. And again, it's one of these transmitter systems that are disordered in this condition. Now, I'll move on very quickly to individual mechanisms. They're short-term in most. Now, one of the important things that determines how an individual responds to trauma is what meaning it has for you, what personal meaning. Sorry, I've skipped along there. Right. expression of trauma in an individual is also is modulated by their past, their present, and the social context in which it happens, and also the individual's cognitive style. There are people, for example, who, when something happens to them, they internalize it. They think it's my fault, it's something I did, or I have control over it. Other people have other ways of dealing with these things. It's the will of God, it's the will of Allah, or Romila, or whatever. And so your cognitive style has an influence on how you process trauma. And the last question, why me? Right? Most of these other things I won't have time to talk about, but they are also important. The mechanisms, how groups, I talked about how individuals process trauma. How do groups process trauma? There are communal support mechanisms, there are cultural norms, spiritual and religious beliefs, and I want to talk very briefly about something called vicarious trauma, that you can experience trauma even when you haven't been directly exposed to it. If it happens to someone close to you, someone dear to you, you can be traumatized by that. Well, I don't need to talk too much about the Civil War here. Everybody knows what happened. Well, most people know what happened. We've had a direct recall of experiences. But very important is not to forget that the Civil War itself was preceded by multiple pogroms. And those in themselves will have been enough to traumatize whole populations, as they surely did. So if you like, it's a series of traumas rather than just the single one of the Civil War. I'll go through this very much. I don't have a lot of time. How do we heal the wounds? This is where I am no longer just a psychiatrist, but I'm also a Nigerian. There are a couple of, I could talk about this the whole day, really. This is something I'm very, very passionate about. By the way, apart from being a psychiatrist, I'm also one of the administrators of the Nigerian Nostalgia Project on Facebook. I've devoted a lot of my time in the last 7 years to studying the Civil War and bringing people together. One of the things I've found that's very useful is the concept of empathy. Now, that's different from sympathy. It is the ability to transport yourself into the experience of another person. And why is this important? It is the reason why I, for example, an ordinary Ijebu boy, who was not born at the time of the war, well, I was born a few months before the end of the war, should understand why an Igbo person can hold me responsible for what I didn't do. That's not to say it's true. It's not an admission of guilt. It's simply an empathetic understanding of where that person is coming from. And why you must understand that people speak in metaphors. So the anger that might come to me, I should understand as a price I have to pay for my circumstance. It happens to me as a doctor. I work in a clinic, a patient comes to see me, and immediately before I've opened my mouth, I've had a chance to upset her. She shows a lot of hostility. It may be that she's just been abused by a husband who is 6'1", and she comes to see a doctor who looks just like him. Right. So it's very important that we bear this in mind and recognize that people sometimes remind us of situations and people that we are not necessarily part of. Thank you very much.